Hello, everyone, and welcome to Henry Schein's series on COVID-19 on YouTube. I'm Dr. Gary Severance with Henry Schein, and it's my pleasure to welcome back Dr. David Reznik, who will be updating us all on all the things related to the recovery from the pandemic. Dr. Reznik, welcome.
Thank you, Dr. Severance, for the introduction as usual, and we'll get started on our Thanksgiving update or our November update on what we are seeing today as far as the COVID-19 pandemic that is still impacting us another Thanksgiving. So what we're going to talk about is an overview of the cases in the US, where the breakouts are. We're going to talk about breakthrough infections. We'll look at cases and deaths by vaccination status, which is again going to stress the importance of vaccination. There has been a withdrawal of a preprint study that overstated the risk of myocarditis, and I think that's something that would be informational for you all. Long COVID in dentistry, that's something again that we need to be aware of, and special steps that we might need to take. CDC's present recommendation for COVID vaccine boosters, which is changing as I'm speaking right now. Pediatric vaccinations, a new medicine, a new oral medicine that's a protease inhibitor against SARS-CoV-2, and of course, something on infection control. So it's a lot, but we're going to get through it, and thank you for joining. So if we look at where the level of community transmission is by state and territory, for once, the South is actually not the worst. So we're not having a big outbreak, probably due to our warmer weather, and even Florida is doing better. But we are seeing a high level of community transmission basically throughout the United States. If you look by community transmission, and this actually breaks it down into Canada, into county level. So you can see most of the country is either at high or substantial risk. There are areas in the Southeast that have moderate risk, and very few areas around our country that do have low risk. So you can actually look into your own community transmission by going to the CDC's website. As of November 15th, 2021, there had been 227 million people, or about 68% of the US population, that's received at least one dose of a vaccine. Of those, about 58.8% of the US population are fully vaccinated. So we still have quite a ways to go. So again, we have about 227 million doses, about 68.4 have received one dose. And remember, one dose really isn't good enough. You need to get both of those doses to be fully vaccinated. And if you've been vaccinated for over 6 months, soon we'll be talking about the booster process. So what about the possibility of COVID-19 after vaccination? What about breakthrough infections? And I think that's something we really need to pay attention to. The vaccines protect everyone who's greater than 5 years from getting infected or severely ill, and significantly reduces the likelihood of hospitalization and death. Vaccination is the best way to slow the spread of COVID-19, and I think we're all pretty aware of it because we've been going to football games and doing well. We've been doing a lot of things outdoors, a lot of big stadiums indoors, and so we're doing better, but we still are not out of the pandemic, and that's one point we still need to keep in our mind. Vaccine breakthroughs happen when a fully vaccinated person gets infected with COVID-19, and they still can spread. So even if you've been vaccinated and you do get a breakthrough infection, you can spread to others. Even when you're fully vaccinated, if you live in an area with substantial or high transmission of COVID-19, you and your family will be better protected if you're going into an indoor public place that's relatively small. If you're going into a big area, you probably are okay, but I'm one of those folks who believe being safe is being smart. I have no desire to have a breakthrough infection. I have no desire to live with long COVID. So I'm taking the extra steps that I need to keep myself and my family and my clinic staff and patients healthy. People who are immunocompromised, such as many of the patients that I treat, may not always build a level of protection that is necessary to keep them out of the hospital for getting sick. So we've already started boosting our patient population here. The CDC recommends that moderately to severely immunocompromised people receive an additional primary dose of the vaccine. So we expect to see some of these breakthrough infections because it is not 100% preventative. It is 95 or 98. So there are going to be a group of people that will have breakthrough infections. Fully vaccinated people with a vaccine breakthrough infection are less likely to develop serious illness. So you'll be home, you'll feel good, but you're going to do better if you're fully vaccinated compared to someone who did not get vaccines. And I think as part of our profession, whether you're a dental hygienist, a dentist, a dental assistant, an office manager, speaking about vaccines and informing our patient population is a service that we do because the oral cavity is a part of the body, and we're responsible for taking care of the whole person. So education is something that we can do to help get people informed and get them vaccinated. People who do get vaccine breakthrough infections can be contagious, as I already mentioned. And we do know that this Delta variant is far more contagious than previous variants that have caused COVID-19, but the vaccines still work. And that is one of the main points. So we do know that the vaccines are effective against the Delta variant and even the sub-Delta variant that we've heard a little bit about that really isn't doing much. It's more contagious than the Delta variant, but it's not more, doesn't make a worse disease. And our vaccines, again, are protective. So if you get your 2 doses and then after 6 months, discuss a boosting, if it's approved at this point, that's something that I highly recommend. But we are seeing some areas in our country where we're really having some crises. And so I'm going to pick out a few. The Southwest states are facing a big surge. We've seen an improvement in COVID-19 numbers, and a part of that improvement was based on the decline in cases in my part of the world. A lot of times I will show you a graph of Grady's infections and how we're managing them and the number of people who are under investigation. The lowest number we hit was in June of this year. It was 6 people in the hospital. At the present time, we have about 25 people in the hospital and about 6 under investigation. Those numbers are far lower than we've seen when we've had big outbreaks in our part of the country. The Midwest is seeing 37 COVID-19 cases per 100,000. The West is reporting 26 cases per 100,000, Northeast 24 cases, and the South is down to 11 cases per 100,000, which is basically the opposite of the other disease I manage all the time, which is HIV. HIV is strongly hitting people in the southeastern part of the United States, but right now, probably due to our climate, we're doing better. Colorado cases, hospitalizations, and death have all been rising. Modeling from the state's epidemiologist shows that those hospitalizations could exceed hospital capacity in December. And this is an issue that our hospitals are facing. We have a nursing shortage in the United States. We have a bed shortage in the United States. If you remember way back to over a year ago or a little more than that, we were talking about having ventilator issues. Right now, we're having issues with ICU beds. We're having issues with nursing. And so that is really reducing the capacity of many of our hospitals to be at full strength. And I think that's something we need to keep in the back of our mind and something we might want to talk to our patients about. Multiple hospitals in New Mexico have activated crisis standards of care, with hospitalizations rising almost 20% in the last 2 weeks. Presbyterian Healthcare Services and the University of New Mexico Health both activated crisis standards of care in November for their Albuquerque metro hospitals, and they're facing challenges managing patient needs amid their surge. New Mexico in October announced the addition of a public health order permitting hospitals to engage in crisis standards of care, so elective surgeries not happening. A lot of GI procedures not happening. Scoping, not happening. So what we're seeing is our hospitals in these high volume states are really being reduced on what they're able to do because they're at capacity and plus. Arizona is both seeing a rise in cases and hospitalizations. They saw a 37% increase in COVID-19 cases over the last couple of weeks, with 47 cases reported per 100,000 residents. The state is averaging almost 2,000 daily COVID-19 hospitalizations, with admissions up 15% over the last 2 weeks. So you're sort of getting this trend that I'm trying to talk about, whereas the South is doing well, where I'm doing well in my clinic and the hospital is doing better, there are other parts of the country that aren't, which is why it's so important that you keep up with where this disease is in your own community, in your own county, in your own state. Despite declining casing trends in Utah, the state has seen hospitalizations rise 17% over the last 2 weeks. And this is a quote. Now we're really in this high plateau of a surge where we have a lot of people with COVID-19 in our state, a lot of people with COVID-19 in our hospital, and fewer resources to be able to take care of them. And so you can see that it's getting a lot of stress on our hospital workers. It's a lot of stress on our physicians, our advanced practice providers, and our nurses. And what can we do to take away some of that stress? Truly is to, again, inform our patients. She said the hospital had to shut down their surge intensive care unit because there wasn't adequate staffing. Again, we might be having a hard time hiring dental hygienists. We might be having a hard time finding dental assistants. And I actually have a hygiene opening right now. But there are many places, and including my hospital, where we do have a vast nursing shortage. This is looking at COVID-19 cases and death by vaccination status. It was a wonderful report that came out of the Texas Department of State Health Services this month. Overall, regardless of vaccination status, people in Texas were 4 to 5 times more likely to become infected with COVID-19 or suffer a COVID-19 associated death while the Delta variant was prevalent in Texas. So they look at August 21, compare with the period before the Delta variant became prevalent in April 21. So they're actually looking at where things were before we had this highly contagious variant and where things are today. From September 4 through October 1st, unvaccinated people were 13 times more likely to become infected with COVID-19 than fully vaccinated people. Unvaccinated people were 20 times more likely to experience a COVID-19 associated death than fully vaccinated people. We can prevent these unfortunate outcomes. All it takes is getting a vaccine and to start trusting our medical system, as 60% of the people in this country have done so far. Vaccinations had a strong protective effect on infections and death among people of all ages. The protective impact on infections was consistent across all age groups and even greater in people aged 12 to 17. In the September timeframe, unvaccinated people in their 40s were 55 times more likely to die from COVID-19 compared to fully vaccinated people of the same age. I think I'll repeat that. Unvaccinated people in their 40s were 55 times more likely to die from COVID-19 compared to those who had undergone vaccination. Unvaccinated people aged 75 years and older were 12 times more likely to die compared to their vaccinated counterparts. Among people with positive COVID-19 tests, including PCR and antigen tests, their number or their N was 1.5 million. 85% were unvaccinated. So these were people with positive COVID-19 tests. 12% were partially vaccinated. They only had that first shot. And 3% were fully vaccinated. Remember, this isn't 100% preventive, but it surely does do a great job of protecting the vast majority. Positive tests occurred more frequently amongst females than males, with 1% missing. The overall mean age was 39 years, still when you're feeling invulnerable, with most positive tests amongst those aged 18 to 29, followed by those aged 30 to 39, and those aged, in my age room, 50 to 64 years old. I'm still in there, but barely. If we look at this population time frame from January through October amongst people with COVID-19 associated deaths, and there were greater than 28,000 deaths, 85% were unvaccinated. About 7% were partially vaccinated, and about 7% were fully vaccinated. And those are people who had high comorbidities, diabetes, COPD, obesity, a blood type cancer, all of those things that we're talking about. Uncontrolled HIV could be a risk. Death occurred more frequently amongst males than females. The overall mean age was 67 years, with most deaths occurring among those aged 75 and older. Remember, older age, comorbidities, followed by those aged 65 to 74 years, which was made about 25%, and then those in my age range, about 26%. If we look at the population description, so this is the age-adjusted case rate by vaccination status, looking at that entire time frame. So looking at from January to October, the rate per 100,000 that was unvaccinated in all ages was over 14,000. The rate per 100,000 of fully vaccinated people was 315.9, 45 times higher in unvaccinated people. The rate per 100,000, when you just looked when the Delta variant was out there in the last month, when more people were getting vaccinated, you can see that the rate per 100,000 in fully vaccinated people was now 13 times higher than unvaccinated. So I think that gives us an idea that some parts of the country are having a difficult time during this holiday season, and other parts need to be very aware that the community spread is still very active. But I want to go to a study that I mentioned. There was a preprint study that really overstated the risk of myocarditis following a COVID vaccination, and a reason that some people were hesitant. So let's talk about why the study was pulled. The study at the University of Ottawa Heart Institute was withdrawn after it was discovered that the study had erroneously calculated the rate of how many people experienced myocarditis, which is inflammation of the middle level of the heart wall after receiving a COVID-19 vaccine. The preprint study claimed that there was a 1 in 1,000 risk of contracting heart inflammation condition known as myocarditis, has been retracted due to a calculation mistake. The CDC reports that as of July 16th, 8.9 million children aged 12 to 17 had received the Pfizer vaccine. Of that population, 9,000 people reported cases of side effects, and 4% of those side effects actually had myocarditis. So 0.01% of all of the children aged 12 to 17 had a side effect, and 4% of that 0.01 had myocarditis. So the risk of myocarditis is very, very small. It's a rare condition in which the middle layer of the heart, as I talked about, becomes inflamed. It can be caused by viruses, medications, illicit drugs, and in extremely rare cases, vaccines. Of the close to 400 self-reported cases of myocarditis in teens in the United States, none were fatal. People who experience myocarditis typically respond well to the medicine and can return to their normal lives within a day. So it's not that fear that was out there earlier on. That study has been retracted. We now know it really doesn't have that impact. What does the dental community need to be aware of when we're talking about long COVID? And this was an excellent article that came out of drbicuspid.com. The patients who have long COVID are generally ambulatory and can be expected to appear in any oral healthcare setting. Given the wide and expanding prevalence of this condition, it is incumbent that all, including oral healthcare workers, all of us, dental assistants, hygienists, dentists, etc., be familiar with and ready to treat patients with long COVID. And this came from two co-authors, was published in JADA, Dr. France, and an old colleague of mine, not that he's old, Dr. Glick of University of Pennsylvania. Because long COVID can affect multiple organ systems, patients with this condition experience a variety of symptoms, include fatigue, respiratory difficulties, renal and hepatic impairments, and psychiatric complications. It is a real thing. It's infecting a broad range of people. You could not gain your sense of smell and taste back for several months. You could be short of breath for an extended period of time, or you might just, due on minimal exertion, become completely exhausted. Both the symptoms and the treatments, including anticoagulant medications, may require patients to receive modified routine oral healthcare interventions, the authors noted. When it comes to providing oral health care for these very important patients, the authors advise reducing complications similar to treating patients with other types of medically complex conditions. So, coordinating and collaborating with the patient's care team, including specialists. The dental medical integration model really depends on both the medical side and the dental side communicating when we're addressing patients who are medically complex. Oral healthcare professionals are encouraged to proceed cautiously with treatment of patients with long COVID, with considerations for shorter appointments, adjustments in chair positioning, possibly due to breathing concerns, and other modifications that will allow these patients to withstand treatment despite their functional limitations. I could not agree more. We do have some patients with long COVID, and we are making special arrangements for them. So let's talk about boosters. Right now, it might be at the time you're watching this, we might have full authorization for everyone to get boosted. But at the present time, the FDA authorized boosters for workers whose jobs put them at high risk of exposure to potentially infectious people, and that includes us. It includes emergency medical workers, education workers, food and agriculture, et cetera, et cetera. But several states on their own are beginning to allow boosting to take place. So, for instance, California, I look at the present time, Colorado, California, New Mexico, New York City, New Jersey, West Virginia are allowing anybody to get boosted. And that would be 6 months after your Moderna or your Pfizer boost. Right now, the Pfizer is the one that is approved for boosting, and 2 months if you've had the J&J booster. And we'll get into that in a minute. The reason the Colorado moved forward was after they reactivated their crisis standards of care for staffing of healthcare systems in the state. So it might not be overwhelming us. We still might be working on getting back to our normal patient level, but our hospitals and our workforces are really getting battered, which is what we can do is to try to get that number down. Because disease spread is so significant across Colorado, all Coloradans aged 18 years old and plus qualify for a booster. She said the state's decision to expand booster eligibility aligns with the CDC's guidance, which recommends boosters for those who are at highest risk because of where you live or work. All Colorado adults who received their second dose of Pfizer or Moderna's mRNA vaccine as of 6 months ago now qualify for the booster. The California Department of Public Health also instructed healthcare providers to not deny booster shots to any adults who are requesting them as long as they meet the timeline requirements. That's 6 months for Moderna or Pfizer. All patients to self-determine their risk of exposure according to their state's public health department. The recommendation comes after the state's initial booster rollout was met with low demand, according to the LA Times. As of November 10th, only 34% of residents aged 65 and plus had gotten a booster. So if you're out in California and you have some older patients, please give them this information that they do qualify, and it will really truly help keep them healthy. For the nearly 15 million people nationwide who did receive the J&J or Janssen vaccine, the CDC recommends that they get their initial shot at least 2 months has elapsed since they got their initial shot. So remember, J&J is the one-shot vaccine. So instead of the 6 months, it's for 2 months. And as I mentioned before, Moderna and Pfizer recipients who are 65 plus or at high risk for infection and who've had their dose at least 6 months ago, according to CDC's eligibility, are available for a booster. Pfizer and their partner BioNTech has asked the FDA to allow booster shots for all adults, and we should have that answer. It could be today as I'm speaking. Pediatric vaccination. So let's talk about that for children ages 5 to 11, based on the Advisory Committee on Immunization Practices interim recommendations. The Pfizer-BioNTech COVID-19 vaccine has remarkably high efficacy against COVID-19 in children aged 5 to 11, and the benefits far outweigh risks of vaccination. It's important to protect our children against COVID-19 and reduce community transmission. And I think that's something we're really not thinking about. Yes, only around 66 children, and that's far too many, have passed away from COVID-19. It's far too many. However, they do lead into community transmission, and that's something we need to take under consideration. On October 29th of 21, the FDA did issue an emergency use authorization amendment for a new formulation of Pfizer-BioNTech's vaccine for use in children aged 5 to 19. And I'll show you the differences. If you're giving vaccinations, I can actually show you the differences in a moment. All persons aged 12 years and older are recommended to receive 2 doses of 30 micrograms and 0.3 ml, 3 weeks apart. So let's go through it and show you the differences here. For 5 to 11, the vial cap is orange. The concentration is much smaller. It's 10 micrograms. The injection volume is at 0.2 mLs. The diluted volume is 1.3 mLs, and there are 10 doses per vial. As far as 12 to 17, it's a purple vial cap cover. It's 30 micrograms, 0.3 ml, 1.8 ml is the diluent volume, and there's 6 doses per vial. Since the start of the pandemic, more than 2 million COVID-19 cases have been reported in the U.S. children aged 5 to 11, and there have been, as I mentioned previously, 66 unfortunate deaths in that age group over the past year. The low-dose Pfizer vaccine for younger children was approved on November 2nd, and the first doses were administered in some locations the next day. There are over 20,000 pharmacies, clinics, and doctors' offices that are giving shots to children aged 5 to 11. Nearly 900,000 vaccinations were given last week, with an expected 700,000 appointed for this week. There are milder side effects associated with those amongst older people in Pfizer's clinical trial. Children aged 5 to 11 had more redness and swelling at the injection site than adolescents or adults. Children also reported more pain at the injection site after the first dose than after the second, although it doesn't appear to be significant. So what were the side effects? Fatigue is the number one side effect, with the second dose being even more so at 39%. Headache was significant, with 22% after the first dose, 28% after the second dose. Muscle pain, again, was a bit significant, with 9% and 12%. And I think chills is something else I'd like to bring up. There were 10% after the second dose, so 1 in 10 are going to have chills. These are showing that the vaccine is actually doing its job. I know it is not the most comfortable thing in the world to deal with, but it's better than having children get sick. So the next topic I would really like to talk about is, what can we do as far as reducing hospitalization and deaths by a pill? So there is a novel COVID-19 oral antiviral treatment candidate, and I'm going to go over the interim phase 2 and 3 analysis. So it's an evaluation of a protease inhibitor for COVID-19 in high-risk patients. We've had protease inhibitors used in HIV and Hep C for quite some time at this period of time, and they did a randomized double-blind study of non-hospital adult patients with COVID-19 who were at high risk for progressing to severe illness. The name of the drug, Paxlovid, which is a mixture of two things, and ritonavir is one of the older HIV protease inhibitors, but in this case, ritonavir is used just to boost the amount of PF07321332 in the blood system. So it actually gives you a higher level of the medication in the blood system. Was found to reduce the risk of hospitalization or death by 89% compared to placebo and non-hospital high-risk adults with COVID-19. Almost 90% just by taking pills keeps you out of the hospital, keeps you out of the ICU, keeps you healthy, keeps you alive. In the overall study population through day 28, no deaths were reported in patients who received the medication as compared to 10 deaths in the patients who received placebo. The scheduled interim analysis showed an 89% reduction in risk of COVID-19 related hospitalization or death from any cause compared to placebo. 0.8% of patients who received Paxlovid were hospitalized through day 28 following randomization. 3 out of 389 hospitalizations with no deaths, compared to 7% of patients who received placebo and were hospitalized or died. That was 27 out of the 385. The statistical significance was highly significant. At the recommendation of an independent data monitoring committee and in consultation with the FDA, Pfizer has ceased further enrollment. There is no reason at this point to show that this works. We know that it works, and we don't want to have the blind component or the placebo component, which puts people at risk for hospitalization or death. And why? Because we know the medication works. Upon successful completion of the remainder of the EPIC clinical development program and subject to approval authorization, it could be prescribed more broadly as an at-home treatment to help reduce illness severity, hospitalizations, and deaths. Another step of getting back to normal. It has demonstrated potent antiviral in vitro activity against circulating variants of concern, as well as other known coronavirus, suggesting its potential as a therapeutic for multiple types of coronavirus infections. Again, a great step in science and a benefit to the people of the world. Now, I would like to look at what we are always so interested in, which is infection control. And OSAP, which is a wonderful organization, has great resources available when it comes to infection control. Researchers reported that in the Journal of the American Dental Association that an extraoral local extractor and a high volume evacuator were most effective for reducing the spread of aerosols during ultrasonic scaling during the dental setting. The study, which also evaluated a saliva injector, found that using ELE cut aerosol spread by 96%, while high volume evacuation reduced it by 88%. So it could serve as a guide to what we do and how we manage and how we keep the aerosol down in our operatories and exposure to our patients, to our staff, and ourselves. So I always believe in the Swiss cheese model. And this is something that looks at personal responsibilities and shared responsibilities. I don't want us to look at it from that perspective, but things that can help prevent us from getting an infectious disease. Physical distancing. Remember, that was one of the first recommendations that came out. If you're sick, stay home. Hand hygiene and cough etiquette. The number one reason of healthcare acquired infections is just simply washing your hands for that full 20 seconds. And just like on my toothbrush, which lets me know when 2 minutes are up, my watch lets me know when my 20 seconds are up. If you're crowded, limit your time. Ventilation and outdoors air filtration is important. So when I look at this message, and then you talk about masks, avoid touching face, et cetera, et cetera. What I look at is the multiple steps that we have. N95s, eye protection, including face shields, disposable gowns, gloves, extraoral evacuation systems, high volume evacuation, relief type systems or isolite type systems, portable HEPA filtration. All of these things combined has kept my staff 100% healthy the entire time that this pandemic has been going along. So again, I believe in using all of these different tools. The one that might be the most hard to create is a negative pressure room. And I'm not sure that we're actually there with this pandemic. As contagious as it is, I don't think we need a negative pressure area, but we do need high volume evacuation plus. Intraoral shields are important. Chairside extraoral suction is important. And HEPA filtration and ambient air treatment, very important. Take all of those steps to protect yourself and your staff. My shield, when I do dental work at this point, stays clean. I don't see splatter. If I don't see splatter because I know the material is going into the extraoral evacuation and the high volume evacuation, I feel safe, even though under my shield, I have on a fit-tested N95. So talking about N95s, the British Journal of Oral and Maxillofacial Surgery measured the blood oxygen saturation and the heart rate of 51 dentists and dental assistants performing aerosol generating dental procedures while wearing an N95 filtering facepiece respirator compared with surgical masks. A clinical pulse oximeter was used to measure the blood oxygen saturation and heart rate at 4 time points prior to putting on the mask and after 1, 2, and 3 hours of continuous use. And there's a source of this at the bottom of the slide. So the SpO2 mean values while wearing an N95 facial fitting respirator at the 4 times were 98.2, 97, 96.6, and 96.2 respectively, compared with a mean value of wearing a surgical mask of 98.8 at all 4 times. The heart rates while wearing an N95 respirator were at 4 time points were 81.3, 93.1, 95.3, 95.4 beats per minute, respectively, compared with the numbers that you see below. So what this means to me is give people a break. Take those masks off after a period of time and get some air. It's really, truly important to do that. Within the limitations of the study, the authors concluded that wearing the N95 respirator for an extended period of time while performing dental procedures reduced the amount of SpO2 and increased the heart rate compared with a standard surgical mask in healthy young individuals. However, the blood oxygen saturation level remained above 95%, which was considered healthy, and the heart rate was also within normal limits. However, I have instructed my staff that after a few hours, please take off your N95 facial fitting respirator, get some air, take a break, get some relaxation, and then go back. I want to make sure that my staff stays healthy and is still comfortable while working. And so far, we haven't had any concerns. So again, I want to thank everyone for tuning in for this. I want to wish everyone a happy and healthy Thanksgiving. If you'd like to have other topics that come up, please do. And with that, I'd like to turn it over to my friend and colleague, Dr. Severance. Thank you again for tuning in.
Thank you, Dr. Reznik, for the continual updates. And thank you for watching. Please email us any questions, concerns, or requests for future topics at webinars@henryschein.com. And please subscribe to our YouTube page by clicking the subscribe button below. And to be notified of any premieres, click the bell icon. Thank you once again for your attention. Stay safe and stay informed.